Much as I am. Me too. Hope y'all have a good weekend. So today we're just going to finish up with the first part of our GI, or the last part of chapter 44. You never know what happens. So next week you do not have a reading quiz next week in here, but you do have a medication or math quiz, right? So know that.
We have an exam, right?
No, I think that's next week.
I apologize, but can I go to my car quick?
What do you need out of your
I need my Spark because I'm super tired and I just needed to give me a boost of
Okay, so you have your medication calculation competency test next week in here. And then it says HTI MedSurg proctored exam. Is that going to be, we have to do that here, so we'll do that first thing. And then it says make sure you fill out your capstone in a program, HTI thing. Evaluation before noon on 9/1, huh?
Oh, our capstone thing was supposed to expire yesterday and it got extended.
Well, she sent us a message. So do that, and then it says, your assessment A practice. Make sure you get all your ATI wrapped up, okay? And then we'll finish up with the last lecture next week. Y'all don't have to hear me anymore.
Next week's our last one.
Next week is she's so sad. She's not coming this sad. No, we have to do class. We're going to be doing week 9, the week after that.
She said that we're going to do the 9 next Thursday and the next Thursday.
Yeah, we're going to do it during our
And
class.
then she said on Friday we're going to take the predictor, but you're supposed to allow 3 hours for the predictor on Friday, so we're going to go over.
Oh, well.
It's 180 questions.
It took the 150 question correction simplex took me like 4 hours.
Just do one thing at a time. Don't overlook
When is the message?
one week at a time. No, you're not. You're going to do one thing at a time. Y'all don't
She said she want us to do. She said she want us to do those before we take the test. Which but I think she should do the message next week.
I think so too, like it kind of
Can we tell her that instead of doing farm first, can we do message first? Because we take that profit at Friday, right?
I can tell her.
Or are we gonna take the
She's probably
message?
late. I'm sure.
Are we taking the message profit on Thursday or Friday?
I would think it's Thursday. Like, don't y'all like coming in and doing it Thursday?
Well, if we do that, we don't get a lot of people here on Thursday at 2:30.
So what do you want to do?
We can do it on Friday.
You want to do the ATI? It's a Friday.
Yes. Wait, don't we have?
That way we can have that review with her.
You have to do your exam on Thursday. No, wait. That's next week's exam.
Oh, okay, the exam. Well, the exam gonna have to be. Yeah, so we gotta. So on week 9,
I'm gonna go home and go to sleep. We can try to get
right?
more.
We'll do it. We'll just do it. Let's talk about that. So right now, let's just get finished up with this, and then we'll look at the other stuff later. We got plenty of time to worry about the rest of that stuff. Yes, we do. Okay, so any questions so far about esophagus, GERD, and the stomach, the intestines, all the ulcers? Any questions on any of that we went over yesterday? I put it on YouTube, and there's 2. I broke it up in the morning and the afternoon so you can see those. Thanks for my 8 subscribers, Jay. Anyway, I should be on there too. Okay, good. So we only have 3 little topics left. Colorectal cancer. Remember yesterday we talked about you can get the Barrett's esophagus, which leads to esophageal cancer, right? So this is the other end of the GI tract, colorectal. Second leading cause of cancer deaths, found in the sigmoid and the rectal regions of the colon. Y'all remember where that's at on your anatomy?
Ain't that one from the fingers descending?
Come down in this area. They don't really know what the cause is. They used to think, just that they had a lot of different theories, but risk factors, if you already have polyps, if you already have ulcerative colitis, if you already have diverticulitis, and then if there's a genetic link, like somebody in your family has had a lot of colorectal cancer, those are definitely going to increase your risk or your patient's risk of getting it, okay? Usually don't have a lot of symptoms. They'll say they're constipated. Like when they've usually been going regular, all of a sudden they've having issues with constipation. Okay? Has everybody got that slide? No. Okay. Too old to stay out too late. Catching up.
Y'all be up there drinking and talking about this. I just see it. Not you, I'm talking about you. I like you.
I haven't graded your paper yet, so. Okay, so when they come in, their assessment's going to be, like I said, they're going to say they're really constipated, or either they're just opposite. They're suddenly having a lot of diarrhea. Why do you think they're having diarrhea? Similar to impaction, but it's a structural obstruction. Something like a tumor is right there obstructing that colon, and so just like a fecal impaction, now the liquid is just seeping around it, so they'll have liquid stool. So they're either going to have none at all because they're so completely, that tumor or whatever the cancer that's growing is so big that it's blocking them completely, or they'll have just a little bit of seepage.
Does it have to be liquid, or what if it's just skinny and ribbon like?
No. Ribbon, as long as it's formed.
Okay.
As long as when it goes into the water, it still keeps its form, that's not diarrhea.
So you ain't got no skin.
They'll have excessive flatus, gas, cramping, because that air and that gas and all that stool can't get through, so that's why they have the abdominal cramps. Vomiting, same thing. If it can't go out, guess where? It comes back out. This way. It's up. And then weight loss, because again, they're not absorbing very well, or the tumor, whatever the cancer is eating up all of their energy.
Is that whenever they have to have surgery to return that, or
Now, we usually go ahead and resection the colon. It's the easiest, because radiation will just kill all of their tissue. In that area. But
what's the resection?
resection, they take out the part that's got the tumor, and then or they use another part, or they put the colostomy in. Okay. All right. So y'all got that one. What are some of the tests that they're going to do to come in with all those symptoms? Fecal occult blood stools. These are our hemoccult cards. The ones where you have to take the popsicle stick and get three different stool samples. Not three from the same poo, 3 different times. And then they check for blood in your stool sample.
What is the one with like the ladies that they do the pap after like 50 and then they just like go in the other hall and take it? They don't do it.
I mean, they just take a smear then while they're in the neighborhood. So, colonoscopy. Y'all know what that is. That's where the scope, instead of going down the throat and into the esophagus and belly like EGD, the colonoscopy is going with the camera up the rectum through the colon with a camera to see where the damage is. What's the vagal nerve? Oh shoot! I just told you. Vagal nerve. Vagal nerve. Remember, we can't stay there and stimulate that one too long. They can do us ultrasound too if it's patient can't tolerate, like if their heart rate's already low and they can't do vagal stimulation, they can do ultrasound. CT said that covers anything and everything. Always pick CT if it's on there. Physical exam with a digital rectal exam to feel if they can feel for an obstruction. And then H&H. What's H&H?
Hemoglobin hematocrit.
Why are they checking hemoglobin hematocrit on a patient with constipation? make sure they're having if they're having rectal bleeding, we want to know if they're not anemic or not, or see if they have cancer, it's going to be a lot lower because their body is using it up faster than they can produce it. Okay, I've got that one. And then CEA, this is on page 1448. Did not know what this is. I had to look it up. Carcinoembryonic antigen. That's what CEA stands for. And it's very limited in use. The book didn't even really give a good description, but it's not really specific to colorectal cancer. So they don't use it as much. It's not really definitive. It's more of a treatment, it said, for or a monitoring tool to see how they're responding to their treatment. It's something that they can do with adults or embryo cells. I've never heard of that one. Just know it's a test to monitor their response to the treatment if they're getting chemo or other kind of meds for cancer, colon cancer. Like I said, I had never seen that, so that may be a real unusual thing.
It's a test to monitor what?
Their response to their treatment they're getting. It's on page 1448. You can read it in my just a couple of sentences. Alright, medical management. Like I said, we're going to do surgery. If the tumor or the cancer is bad enough, they will resection that. They'll take that out, and then that's where they put the colostomy. They open up a stoma onto the outer wall of the abdomen. And we know it should be beefy red, right? It's pale, no good. And then they put the bag on there, and that's the one that you'll have to teach about training. This just becomes absorbed with the rest of their anatomy. It stays in their body because it's still there, but they've taken out the part that had the cancer.
Is it closed off?
Do what?
Is it closed off?
Yeah, they close this off, and it just becomes like, that's still mucous membrane tissue, so every now and then they might pass a little bit of mucus when they have bowel movement, but all of their stool is going to come out of their colostomy because it's coming here first. That's the end of the line.
Is there a particular part that whenever they can't reconnect it, they have to put a colostomy? Like how much of it do you have to lose before?
If they resection it, it has to come out, so they'll put a colostomy on.
But they can't like reconnect it?
If it's up here, they can put the colostomy here. If the cancer's like here to here, they can put a colostomy here. If it's down here, they can put one here.
They can't
No,
just
it's
resection
like
and
it's
then
important.
reconnect it.
If there's enough healthy tissue, they can. But they can resection anywhere. Just depends on how much damage, how much cancer is there, how healthy the patient is overall, and how they can tolerate it.
If they're not healthy, they could probably get another tumor in a different part of it.
They'll pull some of those which would lead to dumping syndrome, remember? Because we got less anatomy. The other thing they can do is radiation, where they just eradicate it. They put the iron blankets, over the other parts that they don't want radiation to, and they just shoot radiation into that exposed area to try to kill the cancer cells. The bad thing about it is it kills all your cells, healthy and unhealthy. So, and then chemo, we all know about that. It's really damaging. But if you're bad, cancer's bad enough, that's what those give you. Okay. Nursing interventions. Of course, we're always going to be assessing bowel and urinary elimination, so I know. But definitely pay attention to the bowel, the color of the stool, the smell of it, how frequent, consistency. Yeah, it's a fun assessment. Urinary elimination. Why do we care about their urinary elimination? We're talking about colon.
Make sure they might be hydrated.
That, but what else? But it's for sure that. What's close to our bladder? The colon. They're all right there together. So can that metastasize? So now if this is here and we fixed this, but we didn't check this, now they're having problems with the bladder. So we want to make sure that that cancer has not spread. But definitely when they're getting chemo, radiation, you want to keep up with the I know because they're not going to want to eat. We don't want them to get dehydrated. Monitor fluid and electrolyte balance, same reason, because we've got less colon to absorb, so we want to make sure that we're getting our nutrients. Tissue perfusion, make sure that everything's getting circulation, like we talked about, the stoma needs to be a pretty healthy red. Give them some pain meds, because this is going to be very tender for quite a while. Gas exchange, that's not this gas, that's airway. We'll make sure that they're staying where they can have good deep breathing, because a lot of times they've got this and they just want to lay in bed and not move, and not do a lot, so you're going to continue making deep breathe, cough, all that. Prevent infection, and then do really good skin integrity. Because those little bags, well, somebody told me the other day when they took the bag off that it tore the skin on their patient. I thought somebody had told me that it had an irritation, maybe it was other class. And they pulled it, and the skin came off with that. So you gotta be real careful.
So they had to move. What they had to do to move it?
They just had to leave it open. We do a lot of skincare, and then that thing oozes, and so they're going in there constantly. And depending on where they put the bag, it smells worse. Yes, definitely.
Oh, that sounds well.
Fecal incontinence, variety of causes. External sphincter may be relaxed. That's just like we have the two sphincters in our bladder. You got a sphincter on your anus, and if it's too relaxed, I don't want to know why, but if it is, then you're probably going to have fecal incontinence. So just know that. Take it easy. Everything in moderation, and you will be okay. Or exit only, I don't know. So, just make sure.
That's patient. Patient teaching.
Yes, patient teaching. Poker face. You have to keep the poker face. No judge. No judging. Voluntary control of defecation is disrupted. It could be from meds. We know as we age that sphincter is going to lose its tone, same as your bladder. So this is something they can't control. Sometimes they've had distension of the rectum because they're really chronically constipated. Remember how I was saying the esophagus can stretch out and hold 1,000 milliliters? Well, your colon can do the same thing. It's stretching out, but they're at the rectum. So if you're used to being constipated right here, it stretches out, and then that makes you have fecal incontinence because it's so stretched that it just kind of oozes out. Or if they've been paralyzed, those nerves from the spinal cord are not running to the bowel to control that sphincter, and so they're incontinent that way. Okay? So any of your spinal cord injuries, they're going to have fecal incontinence. Okay? Medical management, we're going to just try to improve that muscle tone with the sphincter. If they give them meds to kind of help with that sometimes. Bowel training programs, those are limited success, depends on your patient's cognitive ability or physical ability. Of course, if they've had a spinal cord injury, you're never going to get them trained like that. Assist patient to toilet without delay. They're going to call you on your call button and drive you crazy, but if they call, you need to go try to help them as soon as you can. And then provide patient education, good hygiene, good hand washing, diet. What is going to help their diet, and then definitely good skincare, right? So you're going to do a lot of education. Any questions on that one? That's pretty gross. Pretty graphic. Alright, the last one, I know, don't get excited yet. Last one, there was no slide, but this is real easy. Does anybody have a patient with C. diff?
Yes.
Awful. C. diff is a bacterial infection. There's no slides, so I'm just going to tell you what it is. It's in your book on pages 428, the top right column. I had to look for it. It's on our syllabus, so I'm sure there's going to be some test questions, so I want to make sure y'all knew where it was in the book. Page 1428. The column, has divided. The right column, the top is where C. diff is. I'm just going to kind of tell you real quick what it is. The bacterial infection produces toxins. Okay, so the mucosal cells in the colon, they respond to that toxin, and then so they start secreting water to get rid of that toxin. And so you're getting rid of water and electrolytes, so you get dehydrated. The more fluid that your colons get rid of, you can't absorb fast enough, so you get dehydrated. It's a facility-acquired bacterial infection. So what's another word for that? Yes, nosocomial infection. This is so gross. I hate to even talk about it because it makes me want to go take a bath. C. diff spores, they can survive up to 70 days on inanimate objects like commodes, telephones, thermometers, bedside tables, floors, and hands of our workers. So this makes me not want to ever sit on another toilet seat anywhere ever again. Telephone, think about, I worked at a hospital. I know the housekeepers did a good job, they did a good job because really I think when I go back and think in my head, I never saw them wiping the bedside table. I know they never wiped the phone. They did the handrails on the bed, but I know the thermometers, you know, the little machines that you pull around, I never saw anybody cleaning those.
And some of the nurses are girls too.
Yes, some nurses do not have good hygiene. So, and the floor, of course, you know, the 5-second rule never, ever, ever applies to a hospital. Ever. The floor is the nastiest place anywhere. So, know that C. diff is everywhere. Just know that, accept it, and try to do your best to be, you know, proactive in your hand washing and keeping everything clean for your patient. If you don't do that and then you go to the next room, you're going to spread it to your next patient, okay? Healthcare workers have to adhere to the infection control protocols. Will these patients be in a regular room?
No,
Isolation, good. Please. They're going to be on contact isolation at minimal, which is, I think that's gown, gloves, maybe a face shield if it's bad enough. I don't know. We had a patient at clinicals. It was the last day we did clinicals. Remember our little guy that fell? And I went running into the room, and he was on contact isolation for C. diff. Well, I just went in there because I saw him fall, and he had all that stuff out, you know, on the side of his door. And I just went in there to check on him, and they were like, "Don't touch him!" And I was like, just about to, and they were like, "No, he's got C. diff." And I was like, "Okay." So I just monitored. But he had a roommate, and they had moved him out because they didn't want him to catch it. So it was bad. They'll get stool culture samples, test for C. diff. Even if it shows up negative, you still want to, you know, be watching for the signs and symptoms of colitis, bad diarrhea, and stuff like that.
Let me tell you what happened to me.
Okay, tell me.
I had a patient.
Just one time?
Yeah, she's dead now. God rest her soul. But one of my clients was at the hospital, and I had to go see her for 16 hours. You know, nobody told me this woman had C. diff the whole 16 hours I was there. I raised him.
Did you get it?
No, I didn't. I was pregnant too. I was like, y'all trying to kill my baby? I went to that video.
Did you get any symptoms or anything?
I shit regular, so I don't know.
There's nothing wrong with your symptoms.
Nope, my
It's very relaxed.
I don't want to know. Can't understand.
You know, we tell them my business out
Okay. So just know, like I said, if they have C. diff, they're going to be on isolation, and do your very, very best to.
And I think I have a strong immune system because I ate in that room and I didn't know. Like I sat there for 16 hours. And I didn't even know, like, none of this was going on until her sister came in there and gloved up. And I was like, "What you doing?" And she was like, "She has C. diff." I said, "Oh, hey," I called my supervisor. "How you gonna send me to this hospital and tell me that these?" Oh my God. And I did. I ate in there and everything. I'm just.
They didn't have the door labeled or all
I
that.
had my laptop in there, everything. No.
Was it more than 70 days ago? Because
I was pregnant. I ain't had no baby in 4 months.
because they can last for 70 days, so I was just checking.
I like wiped all my stuff down before I like cabin wiped everything. When I took it back out the room, but still that's
Yes. The alcohol is
But it says that it can last for 70 days.
It can last for 70 days, Shenanigans.
Yes.
How long does it
Four.
last?
Well, like, when they start having symptoms, you want to treat it. That's what I'm getting to.
When they're on
That's fine.
contact isolation, they have to use like steril.
Yes, they can't have anything because it's a lot of they're supposed to, they're even supposed to have disposable stethoscopes, like to check your blood pressure with, and that guy didn't. Because we were going to go in and check his blood pressure and everything because he had fallen. So I thought maybe he's dizzy or whatever. We'll check this. And there was no stethoscope, no disposable stethoscope. And the nurses didn't want me using theirs. And I was like, "You don't use yours, go to them." So, I mean, there's nothing can be with that patient that can be reused. Everything has to be disposable.
Even the trays are wrapped in.
I was about to say, how do you wipe down like the bed and stuff? Because if the alcohol wipes don't.
They have a
toilet,
special cleaner once they're done. They clean it.
Is it bleach?
like the
I don't know that
Hayward
it's,
plates or something?
I mean, there's just so many variations now, it's all mutated, there's no telling. So the cause of it is when they're on like a lot of antibiotics. They're on clindamycin, ampicillin, amoxicillin, all our cillins, those are antibiotics, right? And then the cephalosporins. They can kill, all antibiotics kill the bacteria normally, the normal flora that's already in your bowel. And so when that happens, that's why antibiotics give you diarrhea, because they kill all of that bacteria, not just the ones that are causing you to be sick. And so that's why you get diarrhea, because the normal flora is what keeps the stool formed. So what happens is this person, they are taking all these strong antibiotics, and that lets the C. diff flourish in the colon. And that's when you start having the symptoms, severe diarrhea. You want to watch for all that, maybe fever and things like that. They'll have rectal urgency, nausea, cramping, vomiting. But if they've been on antibiotics for a while and they're having liquid diarrhea, think about C. diff. They're high risk for it. Okay.
Will yogurt keep you good?
Yeah, but they usually give them a antibiotics.
It's not just liquid.
It's
It's mucusy, yeah, because it's just shooting right through. The treatment is to stop the antibiotics they're on and give them fluid electrolyte replacement. So you'd give them IV fluids, maybe with some potassium in it, because we know we're going to lose that through a bowel. They'll do a CBC to make sure that they're staying in balance, and then they put them on flagyls or vancomycin, because those are a different kind of antibiotic, and hopefully that will kill the C. diff. Okay, if I'm having bad diarrhea from a bacteria or virus, do you, as a nurse, the nurse's assistant comes to you and says, ooh, they're having bad diarrhea. They just had 3 diarrheas in one day. Do you go and give them an antidiarrheal? No. Why? You want it to get out. If you give them an antidiarrheal or an antiemetic, something that's keeping them from throwing up, and they're sick with a virus, then you're just setting that virus in there longer. So sometimes that's the body's way of getting it out. Diarrhea is trying to flush that bacteria or virus out of its system. So as awful as it is, and it's irritating to certain parts of your anatomy, it's going to be, you need to get it out. Let that diarrhea get out, okay? So do not give antidiarrheals or antispasmodics if they have C. diff, because that just prolongs the time the infection stays in the colon. Does that make sense to everybody? Okay. Any questions on C. diff? What kind of diet would they be on if they had C. diff?
High protein.
They're going to progress to it, but let that cool off. Just until you give them the first day, to let that get out of their.
I haven't seen them do that. I've seen them give them regular food.
You would think they want them to have some formed food to make formed stool, but they start out on food. And always teach hand hygiene. Like she said, the family member came in, you want to make sure you're teaching them that too.
Are those yellow stethoscopes the ones that are just
I think so. They're like real lightweight and cheap. Any questions on GI? Let's take a break, and then did y'all decide what y'all want to do?
There's a movie in your office we should watch the
Oh, we don't want to watch a movie.
we want to Skype Dr. Little.
I have some flashcards of people pharmacology review. A fun way.
I want to watch it. I want to know pharmacology.
Let's take a break.
Let me know what's
Don't forget that your stuff's on YouTube and that your